Good afternoon, everyone. Welcome to this webinar entitled Value of Ultrasound Imaging in Peripheral Nerve Pathology, presented by Ms. Mohini Rawat. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants will be able to identify peripheral nerve sonoanatomy, identify the common peripheral nerve entrapment sites and how sonography helps narrow down the differential diagnosis, understand the importance of scanning non-neural structures as potential source of pathology, and know the role of ultrasound in differential diagnosis and assessment of peripheral nerve pathology. As an ACCME accredited provider, it is the AIUM's policy to ensure that contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Mohini Rawat and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Ms. Mohini Rawat.
Hello everyone, welcome to the webinar. My name is Mohini Rawat. A little bit of background about me and the type of practice I have. I'm board certified in clinical electrophysiology by American Board of Physical Therapy Specialties, and I'm registered in musculoskeletal sonography by Alliance for Physician Certification and Advancement. So in my practice, I utilize clinical electrophysiology and musculoskeletal sonography as part of examination of patients presenting with a variety of peripheral nerve problems. And over the period, I have learned that adding musculoskeletal imaging has filled the void that existed before. Musculoskeletal imaging, ultrasound imaging, gives a structural perspective to looking at patient's problem, and it gives anatomical details of nerve and its surroundings, which is vital in assessment of the problem. So let's begin. I have no disclosures, and objectives of this webinar are as outlined here. We are going to look at peripheral nerve sonoanatomy and how the normal nerve appears in sonographic imaging. Identify common entrapment sites where the nerve can be entrapped and how sonography helps narrow down the differential. Understand the importance of scanning of non-neural structures, which are important because they can be a potential source of pathology, and know the role of ultrasound in differential diagnosis and assessment of severity of peripheral nerve pathology. Okay. So with the advent and availability of high frequency probes, the resolution of ultrasonography has improved considerably. And because the peripheral nerves run a superficial course, they are easy to scan with high resolution ultrasonography. So the most common sites of entrapment are carpal tunnel syndrome, carpal tunnels, cubital tunnel, entrapment of peroneal nerve at fibular head, tarsal tunnel, and there are others, but the most common and the single most common entrapment syndrome in upper and lower extremity combined is carpal tunnel syndrome, and it is also one of the extensively studied entrapment syndrome of all. With ultrasonography, we can study the fascicular pattern of the nerve, which is sometimes difficult to see with MRI imaging. And with ultrasound, we have ability to follow the nerve and follow its course, which is also difficult with MRI in certain nerves because of their tortuous course. Other than looking at the nerve, with real-time ultrasound imaging, we can also look at the surrounding structures which can be a potential source of pathology. And I have some case examples that will make this point much more clear. So let's look at the anatomy of the nerve, internal architecture of the nerve. There are three connective tissue layers. So the outer connective tissue layer in the nerve is epineurium. Inside the epineurium, we have nerve fascicles, and they are covered by another connective tissue layer, perineurium. And inside the perineurium, we have individual axons lined by endoneurium. So from inside out, we have endoneurium, perineurium, and epineurium. And on the left, we have electron microscope imaging of the cross-section of the nerve, and you can see there are blood vessels, and these blood vessels can be found outside the fascicles or inside the fascicles. So there are some intraneural blood vessels. Now on the left, you see a photomicrograph of median nerve, and you can see the fascicles very nice and clear. And on the right, I have an ultrasound image of a normal median nerve, and you can see the fascicular pattern here in the ultrasound imaging. So that's the basis of why we see fascicular or honeycomb appearance in a transverse section of the nerve. Because we are looking at the fascicles, and they are lined by connective tissue layer of perineurium. Now let's look at the normal appearance of nerve on ultrasound imaging. In longitudinal section or long axis view of the nerve, nerve appears as a hypoechoic band with several echogenic lines within two bold echogenic lines. And these two bold echogenic line is the outer connective tissue layer, the nerve sheath, and epineurium. In transverse section, nerve has honeycomb or fascicular pattern or starry night appearance, as you can see on this side. And this honeycomb or starry night appearance is because of the fascicles in the nerve. But they are not always found in all the nerves, at all the location and through the nerve, through the course of the nerve. At some locations, the nerve can be diffusely hypoechoic, and that can be because the ultrasound beam is not perpendicular to the fascicles, and that happens, that happens because of anisotropy. So the diffuse hypoechoic appearance of the nerve can be due to ultrasound beam not being perpendicular to the fascicles, or due to poor local resolution. Other than poor local lateral resolution or ultrasound being not perpendicular to the fascicles, there is one more reason why you see hypoechoic appearance and not fascicular appearance, and that's because of the arrangement of the fascicles in the nerve. So the nerve fascicles can be arranged cord-like, or they can be plexiform. On the left, you see the cord-like appearance of fascicles in the nerve. On the right, you see plexiform, where the fascicles are crisscrossing. So if you have a transducer along this nerve, it's not going to be perpendicular to all the fascicles. And that's why this nerve on the right is going to look hypoechoic, compared to the nerve on the left, which is going to look linear with echogenic lines, parallel lines. So where do we find cord-like or plexiform fascicles? So mostly the nerves which are proximal. So the proximal segment of the nerve has plexiform fascicle arrangement. As the nerve travels distally through its course, it becomes more cord-like. So on the left, we have example of median nerve in the distal forearm, and you can see macroscopically the fascicles are arranged in a linear fashion. Compared to the bottom image, where the fascicles are macroscopically can be seen crisscrossing, or they are arranged, they are plexiform in arrangement. So if you are scanning a nerve and you're going more proximal to it, you may not see a linear echogenic or honeycomb appearance in the transverse section. And that's because the fascicles are not linear, they're not cord-like, they're plexiform. So the most common site of entrapment, the most common entrapment neuropathy is carpal tunnel syndrome. There are other tunnels or narrow areas where nerve travels, and those spaces are potential spaces where they can get entrapped, like cubital tunnel syndrome, which is ulnar nerve entrapment at the elbow, or ulnar nerve can be entrapped at the level of Guillaume's canal. Radial tunnel syndrome or posterior interosseous nerve syndrome, anterior interosseous nerve syndrome, suprascapular nerve entrapment. So suprascapular nerve can be entrapped at the suprascapular notch or sphenoglenoid notch. And most commonly the source of most commonly we see if there is an entrapment, usually you would find a paralabral cyst that compresses the nerve, and the source of it originates from the shoulder. So paralabral cyst can be the reason why suprascapular nerve gets entrapped in the notch, in the suprascapular or sphenoglenoid notch. Tarsal tunnel syndrome, which is entrapment of posterior tibial nerve in the medial ankle. Peroneal nerve entrapment at the fibular head. Or piriformis syndrome, where sciatic nerve is entrapped under the piriformis muscle. Now let's look at the most common entrapment site, carpal tunnel, and how we do the imaging. So to localize the nerve and identify it better, we start with the short axis view or a transverse view of the carpal tunnel. So on the right side of the ultrasound image, we have pisiform bone. On the left, we have scaphoid. Right next to the pisiform, we have ulnar nerve and ulnar artery, and that's the median nerve. So I'm starting with transverse view of the carpal tunnel and tilting my probe to identify nerve from the tendons which are underneath. And as you can see, if I tilt, the tendons become darker, and if I tilt back, they become brighter because of anisotropy of not being perpendicular to the tendons. And once I localize my median nerve here, I turn my probe 90 degrees to go long on it. And now the median nerve can be seen as a hypoechoic band with echogenic parallel lines and lined by two strong echogenic lines. So that's how we localize the nerve. And there are certain measurements that you can take here, which I'm going to talk about in the next few slides. So that's the carpal tunnel sonography. So we start with the short axis view, transverse view, localize the nerve, take the measurement of the nerve, and then go long and look at the surrounding structures like tendon and joint spaces and flexor retinaculum. The next is ulnar nerve at the elbow. So that's the ulnar nerve as it travels distally, and on the right side you have ultrasound image of ulnar nerve above the medial epicondyle, and the next image on the right, bottom right, is ulnar nerve image transverse view at the level of medial epicondyle. The third image is of the ulnar nerve between two heads of flexor carpi ulnaris. So these are the two heads of flexor carpi ulnaris, these, and that's the nerve. And as you can see, the nerve appears different. It's the same nerve that's traveling distally. On the top right image above the medial epicondyle, the transverse view or short axis view of the nerve, it appears hypoechoic, darker, and it's round. As we travel distally and scan the nerve at the medial epicondyle, it's flat and more oval because it's bending over the medial epicondyle. And as it moves distally between two heads of flexor carpi ulnaris, it's brighter and hyperechoic, and you can see actually the fascicles very clearly, these three fascicles here. So the reason here is because the nerve proximally has plexiform arrangement of fascicles, so it is hypoechoic compared to the distal part of the nerve. And the nerve itself is bending over the bone, so the course of nerve is such that it is going to appear hypoechoic here. So it's important to understand hypoechogenicity is not always associated with pathology. It can be a normal anatomy of the nerve for that specific site. Now let's look at the long axis view or longitudinal view of the nerve, of the ulnar nerve. So the first image on the right is longitudinal section of ulnar nerve. The probe is aligned along the ulnar nerve, and you can see the nerve coming distally, and this is medial epicondyle. The second image is of the distal part of the nerve between two heads of flexor carpi ulnaris, and it's hyperechoic and linear here compared to the superficial part. Now, another thing that we can do with real-time ultrasound is we can do dynamic examination, and that's the beauty of ultrasound compared to other imaging modalities. We don't just see static images; we can do dynamic testing. So, in ulnar nerve, for ulnar nerve at the elbow, we can look for any subluxation. So, we put the probe transversely across the ulnar nerve, bridging the olecranon process and medial epicondyle. That's the ulnar nerve. This is medial epicondyle, and that's olecranon. And then ask the patient to flex the elbow and see if the nerve stays in the groove or if it moves out of the groove. And as you see, the patient is flexing. As the patient is flexing more, you can see the triceps, medial triceps coming into the groove area, but the nerve still stays in the groove and doesn't move out of the medial epicondyle, this groove here. If there was a subluxation, you would see the median nerve subluxing out of the groove into anterior part of the medial epicondyle. Now, tibial nerve entrapment at tarsal tunnel. So looking at the normal anatomy of the tarsal tunnel on the medial aspect of the ankle, tarsal tunnel is the posterior tibial nerve travels through the tarsal tunnel along with other structures like posterior tibial tendon, flexor digitorum longus tendon, flexor hallucis longus, and artery and vein bundle. So on the left side, on the bottom left, that's the transverse view of the tarsal tunnel. So this is starting from top to down. This is tibialis posterior, flexor digitorum longus, artery vein bundle, and that the bright structure that you see is the tibial nerve, and at the bottom we have flexor hallucis longus, and we are seeing the muscle part here, and the band that you see on the top is the retinaculum, that's the ligament. And on the right we have long longitudinal view of the nerve. Now let's look at the video clip of the tarsal tunnel. So I have my probe transversely across the tibial nerve in tarsal tunnel, and that's the nerve. These are the blood vessels, tibialis posterior, flexor digitorum longus, and I'm moving proximal to distal, and then distal to proximal to localize the tibial nerve. As you can see, when I'm going down, you can see two branches. It's splitting into two, which is medial and lateral plantar nerve. You can see them again, medial and lateral. I'm distally. Now I'm going to move proximally, and so these two nerve join and become the main trunk of tibial nerve. And once I have the tibial nerve localized, I turn my probe 90 degrees to go long on this nerve. So now we're going to see the longitudinal view of posterior tibial nerve, and that's posterior tibial nerve. And you can look for any other potential source of a nerve entrapment here, like joint effusion or soft tissue masses or ganglion cyst, or any other bony abnormality, a bony spur, or tenosynovitis of one of the tendons in tarsal tunnel that can be secondary cause to the entrapment of the nerve in this area. Now, how does a nerve appear when it is entrapped, or if there is any nerve entrapment? So we see changes in echo pattern of the nerve. So on the left we have normal median nerve. You can see the fascicular pattern or honeycomb appearance or starry night appearance. On the right is a nerve which is involved in the entrapment syndrome. So this is the nerve and carpal tunnel syndrome. So nerve is hypoechoic. There is decreased echogenicity of the nerve, and then there is loss of fascicular pattern or honeycomb appearance, and there is enlargement of the nerve. So we see the nerve becomes more hypoechoic, it loses the echogenicity. And another thing that we see is the nerve is swollen proximal and distal to the site of entrapment, and that we see in the long axis view or longitudinal view of the nerve. So this is the nerve in carpal tunnel syndrome. So if you measure this nerve, this is going to be larger than 0.09 centimeter square. That's indicative of carpal tunnel syndrome. On the right, in long axis view, that's the site of compression, and nerve is swollen proximal and distal to the site of compression, or we also call it hourglass deformity. So let's look at what happens and what's the reason behind hypoechogenicity or decreased echogenicity of the nerve. So when there is a pressure on the nerve, there is increased permeability of endoneural blood vessels. Because of more increased permeability, there is more fluid that enters the fascicles in the fascicle of the nerves, and there is endoneural edema. And because now there is endoneural edema, and there is increased fluid pressure in the fascicles, which causes further obstruction of the vasculature of the nerve, the internal vasculature of the nerve. And because of this obstruction of vasculature, there is injury to the nerve fiber. So that's the vascular causation of nerve compression. So what we actually see when nerve loses its echogenicity or becomes more hypoechoic is because of endoneural edema. So that's the reason behind nerve being hypoechoic at the proximal to the site of compression. Now the chronic changes, two important things that we see with chronic changes in the nerve when it's compressed in an area of entrapment. These chronic changes involve fibrosis, so there are connective tissue changes, and there is thickening of perineurium and endothelial layer of the vessels inside the nerve. So we see connective tissue changes. So other than hypoechogenicity of the nerve and swelling proximal and distal to the site of compression, the connective tissue of the nerve is thickened, and there will be fibrosis in chronic entrapment. Now let's look at the most common site of entrapment, which is carpal tunnel syndrome. There are several measurements that we can use to look for indications for, or to find if there is any compression or entrapment of the nerve or not. So the first one is increased cross-sectional area at the level of pisiform, and that's the single diagnostic measurement or single sonographic measurement with the highest diagnostic accuracy. It has sensitivity of 87.3% and specificity of 83.3%. So this is the single best sonographic measurement. So if you have to pick one of the measurements out of the 5 here, I think I would pick a cross-sectional area measurement of the median nerve at the level of pisiform. Then we have in flattening ratio. So how we measure flattening ratio? We measure medial lateral dimension of the median nerve at the level of hook of Hammett, and we measure AP dimension, and we divide medial lateral over AP. And if the ratio is more than 4:1, that's again suggestive of carpal tunnel syndrome. Then we have wrist to forearm ratio, where we measure cross-sectional area of median nerve at the level of forearm and wrist, and we see if that ratio is more than 2.5. Then we measure palmar bowing of flexor retinaculum. We measure the distance between pisiform and scaphoid, and then measure the distance from that linear dimension to the flexor retinaculum. If it's more than 3 millimeter, that's again is suggestive of carpal tunnel syndrome. And the last one is a swelling ratio, where we measure maximum cross-sectional area in the carpal tunnel region in the wrist, and measure the cross-sectional area of median nerve 4 centimeter proximal to the wrist, and see if the ratio is more than 2.5. So there are various measurements, but the single best is the cross-sectional area, the pisiform. And like I said, this is the carpal tunnel syndrome being the most common one and extensively studied. We have more measurements that we can use in this entrapment compared to others. So we rely on qualitative and quantitative assessment of the nerve. So we will look for if the echogenicity of nerve has changed, or if there is any nerve caliber change proximal and distal to the potential site of compression. So now let's look at the case. This is a 57-year-old female who was involved in motor vehicle accidents just 12 days ago before she presented to the clinic. And that resulted in contusion of her left wrist, and she developed numbness tingling in first three digits. So we are thinking of, yeah, she is getting something like carpal tunnel syndrome and entrapment of median nerve at the wrist, secondary to trauma. With EMG studies, we found conduction block of sensory fibers of median nerve, and motor studies were normal. So this is the case of a patient where she never had any wrist symptoms before and just developed very recent. So we are looking at the acute and recent onset carpal tunnel syndrome. So let's look at her transverse view of median nerve. So this is how her median nerve looked like. So it's enlarged. There is some hypoechogenicity of the nerve, and in longitudinal view you can see the nerve swelling proximal to the site of compression. So there is proximal swelling. So yeah, this is carpal tunnel. This is how it presents. EMGs are positive, electrophysiological studies positive, ultrasound is suggestive of carpal tunnel syndrome, but we can get more information out of it. Now look at her nerve at the site of maximum enlargement, which is this area. Now on the right I have a reference image of how the fascicles are arranged. So the red that you see, those are sensory fascicles. The green that you see is motor fascicle. And if you look at the nerve, the darker fascicles are actually similar to what you see on the right side. So, and with EMGs, with EMG study, we found sensory complete conduction block of sensory fibers, and motor studies were normal, and it correlates with the ultrasound finding of sensory fascicles being more hypoechoic. That means they have intraneural edema compared to the motor fascicles. Now let's look at the cascade of nerve compression. So based on some animal experimental and intraoperative studies, we have the pressure measurements. So at 20 to 30 millimeter of mercury, there is reduced epineural blood flow. At 30 millimeter of mercury, there is impaired axonal transport with subsequent increase in endoneural pressure. At 30 to 40 millimeter of mercury, we get symptoms of paresthesia. At 50 millimeter of mercury, there is an epineural edema and axonal transport block. At more than 60 millimeter of mercury, there is total intraneural ischemia with complete sensory block followed by complete motor block. So in the case that I just presented in this slide, with EMG studies, we had conduction block of sensory fibers, and the motor studies were normal. And with ultrasound imaging, we looked at the structural part of the carpal tunnel, and we looked at the fascicles that were involved. So all this, if you put all this into together, all pieces of the puzzle put together, they all point towards the vascular causation of carpal tunnel syndrome. So this is acute carpal tunnel with the vascular causation. So in chronic cases, it's important to know that the vascular causation is superseded by other processes like fibrosis. So it may be difficult to isolate the fascicles if the condition is chronic, because there is not just the vascular cause, there is fibrosis that has set in, connective tissue changes, and more than one type of fibers get involved. Now the next case is a male, 47-year-old male with complaint of numbness, tingling in the right first 3 digit, again median nerve distribution. But this happened after an episode of hitting a PVC pipe. He was working around the house and just fixing something, and he was for some reason hitting the PVC pipe with his volar aspect of wrist. So we did EMG studies on him, and we found mild to moderate compromise of the median nerve, but we found that bilaterally. So that's strange. He has symptoms only on the right side, but we see EMG is positive for median nerve compromise bilaterally. Because we do both the tests in the same facility, we didn't stop there. We do more sensitive studies to tease out what the problem is. So we also found, in addition to that, there is a conduction block of sensory fibers at the wrist, at the carpal tunnel. So this probably we're looking at some subclinical carpal tunnel, and we can call this false negative. But let's look at the ultrasound image of this patient who presented like very similar to carpal tunnel presentation. This is how his nerve looked in a transverse view. So this is hypoechoic nerve enlarged. But look at the nerve in long axis view. There are signal changes focally at the site where he was hitting his hand with the PVC pipe, and the nerve is normal, distal and proximal to it. So now let's move longitudinally more proximal in the next slide, and you can again see the nerve is normal in its echo texture, proximally and distally, and just focally. Focally at the area of the trauma, there is signal changes. So it's with ultrasound imaging, you can actually see the structural changes and understand the physiology, and it actually gives a very good perspective to looking at the problem rather than just looking at the functional aspect and basing everything on just electrophysiological studies. The next case is a 76-year-old female with history of diabetes and spinal stenosis. And she also has other comorbidities like hypertension, hypercholesterolemia, and she had swollen feet. She came with a complaint of recent onset of foot flop when she's walking, and that happened like recently, since past few days. And she was referred because there was a suspicion that maybe she's developing neuropathy, which is asymmetrical, or there is worsening of spinal stenosis, or it's although it's less likely, but there is also we can to rule out fibular nerve entrapment at the fibular head. So doing the electrophysiological studies, we found there is peripheral neuropathy, but it is symmetrical. It's symmetrical in both extremities, so there is nothing in the EMG studies that came up that can explain her foot flop. So foot flop because she has foot flop, this is definitely she has weakness of dorsiflexors of the foot. So let's look at the dorsiflexors of the foot. So let's look at anterior view of the anterior anatomy of the ankle. There are 3 tendons from medial to lateral: tibialis anterior, extensor hallucis longus, and extensor digitorum longus. So that's the transverse view here. And you can see from medial to lateral, tibialis anterior, that's tibialis anterior. This is extensor hallucis longus, and that's extensor digitorum longus. And in the longitudinal view, you can see the tendon linearly as a linear structure, all the linear fibrillar pattern of the tendon. This is distal end of tibia, that's talus, and that's the ankle joint. So this is how the tendon is arranged. Now, we decided on doing an ultrasound because nothing in the EMG could explain that, and it was a sudden onset. There has to be something that's going on. And so this is how our ankle scan looked like. Tibialis anterior, extensor hallucis longus, and extensor digitorum longus. So if you see on here, she had a full rupture, complete rupture of tibialis anterior tendon, retracted proximally at the level of distal end of tibia. She had a complete rupture of tibialis anterior, and that was the reason for her foot flop. Going a little bit more distally, you can see the empty sheath here, no tendon. Going further more distally to the attachment site, and there is no attachment. So tibialis anterior attaches to medial cuneiform and base of first metatarsal, and you cannot see any tendon here. So that's why it's important to look at the structure with musculoskeletal ultrasound imaging, because sometimes you can get answers with that. Now, I have that image again here. When the patient presents with a lot of swelling around the area, especially people with the comorbidities like heart diseases and hypertension, hypercholesterolemia, or some other connective tissue disorders, they have swelling or edema in the feet, and if they have a rupture of a tendon, it's hard to physically with physical examination, it's difficult to know because you cannot palpate the stump, proximal stump of the tendon. So in her case, it was not visible, the ankles were symmetrical, and the stump was not palpable. And as you can see, the subcutaneous layer, there is a lot of edema, and because of that, it was not obvious unless you do imaging of the ankle. Okay, another case. This is a case of 47-year-old male with the numbness in the left first 3 digit, again, median nerve distribution. He has, out of all 3, he has more symptoms in the 3rd digit, the middle one. And his pain was radiating from wrist to forearm, and we do see that this carpal tunnel syndrome. In carpal tunnel syndrome, the pain can radiate up to the forearm or shoulder. So his symptoms duration was 2.5 months. He also had some laceration in his left 3rd digit, but it was more on the dorsal side of the finger, and there was no, it was not deep enough to injure any digital nerves or any other important structures. But because of that, he developed some stiffness in the 3rd digit. So with EMG studies, we found moderate carpal tunnel on the left, so that makes sense, right? Patient has symptoms in first 3 digit, which is radiating up to the shoulder, and EMG confirms that there is an entrapment of median nerve at the carpal tunnel. So I think we have all the answers here. but maybe not. So we decided to do imaging, and this is how the transverse view of the nerve looked like. And on the right you can see the median nerve. So yeah, it is hypoechoic, some decrease in echogenicity, and there is some enlargement. So again, it is median nerve, already confirmed with EMGs. We do ultrasound and it confirms that diagnosis. So looks like there's nothing more to know in this area. But when I do imaging, I usually go along the course of the nerve and not end right at the site of entrapment. So I imaged this nerve a little bit more distal and proximal. So when I went a little bit more distal, right at the distal, going a little bit more distal to the carpal tunnel, so we are in the palm area now, I saw a sudden increase in the size of the nerve, more than 4 times the size at the level of the wrist. And in longitudinal section, you can see that the nerve is swollen and increase in caliber and hypoechoic. This is the area from where you would start seeing like small nerve becomes thinned out and it branches out into digital nerves, but we see a sudden. And later on, this is confirmed to be an intraneural fibroma. So there is value in following the nerve at least a few centimeters distal and proximal to the site where you're suspecting of the compromise. Now, next patient, he came and he had the only one complaint and nothing else. He said he has numbness on the ulnar aspect of the 4th digit. That's the only complaint. He had nothing, no other symptoms, just the numbness on the ulnar aspect of the 4th digit. And the EMG study was inconclusive. We did not find any signs of entrapment at the level of elbow or at the Guillaume's canal or any other generalized neuropathy. And nothing that came conclusive. We did do some orthodromic studies recording from the ulnar aspect of the 4th digit and compared it side to side, and that came abnormal, but that still did not help narrow down or localize the site of lesion. So now we did the imaging and followed the ulnar nerve. We scanned the ulnar nerve at the elbow and followed it down and scanned it at the Guillaume's canal and followed it to the 4th digit, especially the ulnar digital nerve of the 4th digit. And that image that you see on the right is of the 4th digit. That's the flexor tendon. Underneath you have proximal phalanx, that's the bone. Here is the digital artery on the radial aspect. The small one here is the digital nerve. On the left side you have digital artery, and that is the digital nerve. The longitudinal section at the same area, the longitudinal view, you could see there was a soft tissue mass. So this is a soft tissue mass of neural origin on the ulnar aspect of the 4th digit, and you can see the blood vessel under, or the digital artery underneath the soft tissue mass, and you can see the same in the longitudinal view. So this turned out to be a neurolymoma after its resection and biopsy. So it's important to explore the area, move along the course of the nerve, look for any other pathology, maybe a nerve tumor or any other sources of pathology in the surrounding area, any other structure compressing the nerve, rather than just staying in the entrapment site and looking only at the nerve. This is another example of a patient presenting with the carpal tunnel syndrome, where everything was indicative of carpal tunnel syndrome, like and no other pathology other than entrapment of median nerve at the carpal tunnel. With ultrasound imaging, we found a cystic mass over one of the tendons of the carpal tunnel. So this is an FPL tendon, flexor pollicis longus. The longitudinal view, you can see the tendon and the cyst over the flexor tendon sheath. So from left to right, that's the ulnar site. So this is pisiform bone, and that's the ulnar artery, ulnar nerve. That's flexor retinaculum, and that's median nerve. We cannot see the tendons very clearly because we are not perpendicular to them. But FPL tendon, flexor pollicis longus, is the radial, is on the radial side, and it's the radial. It's on the radial side of the median nerve. So if you have difficulty localizing the median nerve, if you ask the patient to bend the thumb and ask them to, you can localize the median nerve because it's the radial most structure. So in this case, the patient had ganglion cyst that was arising from the sheath of flexor pollicis longus. So other possible causes of nerve entrapment can be ganglion cyst or intraneural cyst, tenosynovitis of the tendons around the nerves. There are a lot of structures that are traveling along the nerve, and if there is any inflammation of those tendons or any soft tissue mass or a cystic structure arising from the structure, that can compromise the space and can cause the entrapment of the nerve. That would be secondary compromise of the nerve. And these space-occupying lesions can be different types of soft tissue tumors. Giant cell tumor is the most common benign tumor of tendon sheath. That could be a possible source of the compression. There are anomalous muscles. Sometimes they are compromising the space in the tunnel, and these are the possible causes of nerve entrapment. And that's all. Thank you. And if you have any questions, I can take them. Okay, trying to open the questions. Okay. Okay. So first question that I have is, how do you evaluate carpal tunnel when there is bifid median nerve? So there are like 9% of population with bifid median nerve. So all the measurements for cross-sectional area, normal measurements, are not established with considering the bifid median nerve. So I usually measure both the nerves, the bifid median nerve, and add them and see if they are greater than 9 millimeters square. But I also evaluate that qualitatively, looking at the echogenicity of the nerve, and if I see any enlargement proximal and distal to the site of the nerve. The next question I have is, what's the prevalence of cubital nerve entrapment? I think you meant ulnar nerve entrapment at Guillaume's. So it is less compared to cubital tunnel. So ulnar nerve is most commonly entrapped at the elbow compared to the wrist or Guillaume's canal. But I don't have a specific number right off my head that I can give you, but it is definitely less compared to the elbow. Okay, the next question I have: when measuring the carpal tunnel area via trace, should we include the epineurium? So when I measure, I try to stay inside the bright line. So you try to stay inside the epineurium, but on it, but inside it. So you don't want to underestimate it. For forearm, there is no anatomical. So the next question is, what is the anatomical landmark for forearm nerve measurement? Because in forearm we don't have any bony measurement. The muscle is traveling between the muscles. We use the measure, we go 4 centimeter or 12 centimeters. So the forearm ratio that I gave you, the swelling ratio was at the 4 centimeter, and the forearm ratio you can use 12 centimeter in that. Next question is, can you give us the criteria for ulnar nerve compression at the elbow? Ulnar nerve measurement, so like I said, median nerve is more extensively studied, so those norms are very, there is a consensus that we can use 9 millimeter square as the norm, and anything above that is suggestive of carpal tunnel syndrome. But for ulnar nerve, they are not as rigorous. So based on ultrasound literature, the number is 6 millimeters square, but what I see is when I use that as a reference, I include a lot of false positives. So again, I'm looking at the nerve qualitatively, and also looking at how if there is any focal compression, or I see sudden change in the caliber of the nerve. And this is my own opinion. I use 9 millimeter square to stay on the upper limit of the literature, but based on literature it's 6 millimeter square. But I find that I get a lot of false positives with that measurement. Okay. Next question. How did you know to use Doppler imaging in one of the case studies? So as a regular practice, when I do ultrasound imaging, I always use color Doppler to look for vasculature around the structure of interest. And I think that's very important because cyst and blood vessel can be confusing if you're not looking at structure in 2 views, and also if you're looking at any soft tissue masses, to differentiate. Sometimes to differentiate solid from cystic, you have to turn on the color on and see if there is any vascularity. And there are many more reasons why you should always turn on the color Doppler whenever you're doing ultrasound imaging to check for structure or vasculature around. Another one is for tendon pathologies. If there is any new angiogenesis, you want to use the color Doppler to document that if you notice any angiogenesis, new angiogenesis. Okay. Now the next question is, can a scar tissue be differentiated based on echogenicity? Scar tissue, so you have to, scar tissue is a random arrangement of the, it's a random arrangement of collagen, so you can differentiate it. It depends at what area you're looking for scar tissue. What I do is I look for normal anatomy, and based on the history of the patient and where the scar is, you can differentiate it. It looks diffusely hypoechoic. That's how you can differentiate it. Next question is, can the sciatic nerve get trapped in pisiform? Yeah, that's one of the entrapment sites, so the answer is yes. What is the cutoff for nerve size in tarsal tunnel? So the cutoff for, again, like other nerves other than median nerve, and not all the nerves are extensively studied, but we can use 0.22 centimeter square as a cutoff for tarsal tunnel. Where do you measure the median nerve, and does it change with respect to left-handed people? I measure the median nerve at the level of pisiform. That's where the normal values are established. That's the anatomical landmark. And I don't think side to I can say that the side left-handed people or right-handed people, it changes. I think it's more or less the same, but I don't think I have extensively studied that to comment on that. What are the criteria for median cross-sectional area at the pisiform for carpal tunnel? So if the nerve is larger than 9 millimeter square or 0.0 centimeter square, that is suggestive of carpal tunnel syndrome. Okay, now let's look at the next question. Do you perform serial ultrasound to track physiological improvement in carpal tunnel or ulnar neuropathy at the elbow? Yes, I do. I actually work very closely with the other physician and surgeons, and we do post-operative, pre and post-operative, or pre or post intervention studies, and there is decrease in the cross-sectional area of the nerve after it has been released. So the answer is yes. Next question is, what are the top 3 things ultrasound appearance of an entrapped nerve? So two most important things is change in echogenicity of the nerve. So nerve appears hypoechoic, or there is decreased echogenicity of the nerve. There are 2 ways of saying it. So it becomes darker. The second is there is enlargement of the nerve, proximal and distal to the site of compression. These are the 2 important points to remember when you're looking for ultrasound appearance of entrapped nerve. Next question, do you routinely incorporate EMG, ENCV studies combined with sonography in your examination for suspected peripheral nerve? And yes, I do that, and it's invaluable. I think we don't have enough time, but I have like great cases that I have missed out. I would have missed out on a lot of details if I missed one or the other. So I think together they complete the assessment of the problem. You're looking at the function of the nerve when you're doing the electrophysiological studies. When you're doing ultrasound, you're looking at the structure. So it's like function and structure. You want to see both. Now let's look if I have missed any of the questions.
I think that's it for tonight.
All right.
So thank you very much to our presenter, and on behalf of the AIUM, our thanks to all of you who have participated in today's webinar. Please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and that you'll join us again for future webinars. So long, everyone.